Hi, I'm Will. Welcome to ResearchPod. Brains, blood, and a beating heart are top of the list when it comes to thinking about your body and your health. As we get older, the odds increase that something, somewhere among those three, will eventually go wrong. But what if that could be put off for as long as possible? Understanding blood flow to and around the brain is part of research into brain aging, and part of the work of Dr. Lucy Bachon and Dr. Jatinder Minhas at the Cerebral Hemodynamics in Aging and Stroke Medicine, or Chiasm Lab in Leicester Royal Infirmary. Today we're chatting about some of their research into developing methods to help you offset the progression of diseases such as stroke and dementia, and helping patients to keep their edge. Lucy, Jatinder, hello.
Hi.
Hi there.
Lucy, if we could start with your personal background and what's led you to everything that we're chatting about here today.
Yeah, so hi, my name is Lucy. I'm currently working as a clinical research fellow funded by the Dunhill Medical Trust at the University of Leicester. And the reason I am where I am is probably due to some work experience I did many years ago as a sixth form student in a care home, where I really loved working with older people and just learning about them and the stories they had to tell. So this has led to me now working in a clinical environment with older people and really now doing research with older people, and particularly with people living with dementia, which is my research interest. Working with older people and particularly people living with dementia has its own special challenges, especially consenting or recruiting people to research studies. My patients often forget sometimes why they're there and what they're there to do. So just giving them lots of gentle reminders and really sort of considering the person in front of you throughout the study is really beneficial. But from my experience, I've found it a really rewarding experience, and involving people with dementia in research, I think it's also beneficial for them and they get a lot out of it in return. So it's a two-way process, really.
And Jatinder, a little bit about your personal and professional background as well, if you'd be so kind.
So I'm Jatinder. I'm a current NIHR clinical lecturer, and like Lucy, I was previously funded by Dunhill Medical Trust for a clinical research training fellowship. Probably from finishing sixth form and starting sort of postgraduate studies, I always had an interest in the whys and wherefores. What's the reason that we do what we do, particularly when it comes to healthcare? And it sort of led me down the path of researching a variety of different topics. And then eventually I narrowed down into stroke care. And I quite liked at the time as a junior doctor, looking at radiology scans. I quite liked being busy looking after acutely unwell patients. But equally, I also liked the stories and the challenges looking after older people presents. And those things married together really led me down to really realizing that I enjoyed looking after patients that had suffered stroke and trying to sort of improve, number one, how they understand this disease that's very disabling, but number two is also how we can try and improve their outcome through a variety of different strategies. And I'm fortunate that the research has led us where we are today, and that despite 10 years worth of exciting evolution in stroke, there's still so many questions to be answered. And I guess that's a lot of what research is about, really, that for every question you feel like you're trying to find an answer to, you end up creating another 5 different avenues of research directions. So I think that unfortunately between Lucy and I, we've had a chance to work together in the crossover period between our fellowships, which has been really nice. And focusing primarily between us on stroke and dementia.
To get outside of the clinic a little bit, I understand that also putting your best foot forward in the quite literal sense with, was it a 10K run or upsetting distance of exercise that you guys were working on, which I, who've been indoors for 20 months, cannot physically comprehend doing.
Yes, Jatinder's roped me into a few charity runs, which we've been doing together. I think the first one we did was the Presswold Hall 10K run. We started off there, and he's upped the challenge this year with a 10-mile Chase the Sun run. So we had to chase the sun before it set and get 10 miles in. And we did all that for the Forward Stroke Group, which is our local stroke support group for stroke survivors in Leicester. And Jatinder has upped it one further, which I haven't joined him for on this occasion. He's doing the London Marathon in is it just under a week, Jatinder?
Yeah, this coming Sunday, I will probably be found crawling at some stretch across central London somewhere, needing to be rescued. But no, I mean, I think it's been really nice. As Lucy mentioned, Forward Strokes Group have provided us with so much input into some of our research study design, providing a bit of a sounding board, and also invite us to speak to the group about some topics, particularly because they've got a wide variety of patients and carers. And I think they've been affected by the pandemic, as have many, many different charities and groups. And we just felt that it would be nice to provide them with a bit of support as they transition back into having face-to-face meetings. And obviously, resources change and things like that. So it's a challenging time for charity. So hopefully that will help them.
When it comes to the research projects that you're working on under Dunhill Medical Trust, who or what kind of projects get funded, and then how that's led to work on hemodynamics that brings us all together?
As Jatinder mentioned, the Dunhill Medical Trust have funded both of us in recent years for our research projects. Mine was called the Cognition and Flow Study, and it looked at the effects of brain training, which is a little bit controversial, but on how that affects brain blood flow. And I did that in healthy older adults and people living with dementia, particularly Alzheimer's disease, and also mild cognitive impairment, which is sort of an early form of dementia that is a high risk group that might go on to develop Alzheimer's disease or something similar. And I met my participants at baseline, did the brain blood flow assessments using a technique called ultrasound, which is also used by Jatinder, and split them into two groups. So half got allocated to the brain training. They went off and did some brain exercises on a computer for about 3 months, and then the other half just carried on as normal. Then they all came back for a follow-up assessment at the end of the study, where I measured their brain blood flow again to see if there'd been any changes from the baseline assessment. And I also interviewed the participants to see who did the training, to see whether it was something they enjoyed, whether they didn't like it, is that something realistically they would do in the future. And I had a lot of fun running that study and trying to get brain training running on some very old computer systems was also the technical challenge for me. And I'm not much of a technical person, so that was very interesting.
To maybe set the scene a little bit, if we could give a brief overview of brain aging as a whole, to kind of understand when it is working, what's going right, and then as age comes on, what kind of things start going awry and how training either fixes those problems or shifts the timeline of them.
As the brain ages, it doesn't work as well as it should do. And I think a lot of older people listening to this may or may not agree with that. But as we get older, certainly what the research shows is that our memory sort of function and our ability to learn new things does decline with age. And brain training is something that's been talked about a lot. People have probably heard a lot about it in the news and the media. Does it work? Doesn't it work? Nobody really knows. Is it any better than doing a crossword puzzle? Jury's still out on that a bit. But it's one technique by which we think we might be able to stop or slow down that kind of cognitive or memory decline with aging, or certainly potentially delay the onset or development of dementia. And brain training itself uses basically different kind of exercises to stimulate the brain on a regular basis and try and essentially train it to be faster, more efficient, and improve the way it works. Where blood flow comes into this is that blood flow in recent years has been found to be very important in dementia. We know that healthy older adults who have lower brain blood flow have a much higher risk of going on to develop dementia in the future. And we can actually predict to some extent the people who will go on to get dementia and those who won't, just based on the brain blood flow in a healthy older adult. So if we can change that, so if we can improve the brain blood flow, if we can change the way the brain handles its blood flow, so the brain is able to control its own blood supply, which is quite clever. If we can change its ability to do that and make it more efficient and functional, perhaps we can also improve the way that the brain works and improve memory and the other things associated with memory, so cognitive function in general.
Jatinder, does this have much overlap with the stroke patients that you've been working with? Because when it comes to brain blood flow, that's kind of the worst case scenario.
Absolutely. So the overlap is twofold, really. Number one is in the method with which we visualize the blood flow, which, as Lucy mentioned, is this ultrasound technology. Now, it's important, and this will probably link in when we explain what chiasm is a little bit later. We're fortunate that we've had some training in ultrasound-based technologies, and between Lucy and I, we've probably done several hundred measurements now, both on healthy volunteers and patients. And in the UK, there really aren't any other centres that have the sort of volume of research scans that we do with ultrasound looking at brain blood flow. But also, between Lucy and I, we've managed to sort of master some of these paradigms. And by that, I mean some of the challenges that we put brain blood flow through in order to understand how it's controlled. So from a dementia perspective, it's doing things like challenges. So whether that's a memory test, whether that's doing sort of different complexity tasks. And from a stroke perspective, we do things, for example, like alter brain blood flow to look at how well it's being controlled using breathing exercises. So perhaps breathing a little bit faster or breathing in some inhaled gas. Things, for example, like squats, looking at different postures, different head positions. And the reason it's important is because across the world, there's lots of studies that are done in a manner where we compare different things. A good example is head position. So keeping somebody flat after they've had their stroke on the bed, or perhaps keeping them at 45 degrees, has been a very contentious question for many years. And a large-scale study that recruited about 10,000 patients across the world didn't really conclude either way that there was a preference. So that's helpful because it means that theoretically we could do either. But what it doesn't really do is explain on an individual patient basis whether there are some people that are benefiting from it and others that aren't. And that's where studies like ours, which are what we call sort of mechanism-based studies, where we're actually looking at what's happening in real time to blood flow in patients that are suffering from dementia or patients that have just had a stroke, where there's lots of changes going on with blood pressure. That's where there's the beauty in looking at something in real time, rather than perhaps just taking a snapshot that you sometimes get with a CT scan or an MRI scan. So it's very exciting, and we're fortunate that because we've now got a good grasp of these methods, so using ultrasound, it means that we can try to look at larger numbers of patients within our studies, perhaps at different time periods. So maybe where there's been a bit of a focus, for example, on looking at acute stroke. In the future, I'm quite keen to look at patients perhaps that had their stroke maybe a few weeks ago, months ago, to look at what's happening to blood flow in the longer term. Because what does link both stroke and dementia together is, unfortunately, once you've had your stroke, downstream, we're talking certainly months to years, but perhaps even some patients report for several weeks after, there is this memory impairment, this problem with recall, or sometimes sort of more complex memory processes that's often affected. And so hopefully there's a lot of alignment with the fellowships that we've both done, because it does give us the opportunity to begin to answer some of the big questions that perhaps are on the horizon.
So then on to one of my favourite institute name acronyms in a while, the Chiasm Lab. What kind of work is happening there?
It's based on the Cerebral Hemodynamics in Aging and Stroke Medicine Research Group. So I think you can probably see why we've shortened that. But essentially it's brain blood flow in any sort of disorders of aging or healthy aging. And particularly, as we said, we focus on things like stroke and dementia, because those are probably the two of the biggest disorders of aging, really, that we encounter, certainly in our clinical work as well. And our research group's a bit unique in the sense that it's a collaboration between clinicians, so people like myself and Jatinder, who sort of work at the front line with people either with stroke or dementia, or generally older adults. But we're also supported by a number of scientists whose background is really in medical physics, and they have expertise in things like ultrasound and MRI scanning. We also work with clinical engineers, and people who can do sort of more computer modelling, software development, those kind of things. And we all work together really and collaborate on various projects to answer these questions that Jatinder and I have been discussing around sort of stroke, dementia, brain blood flow, and using tools like ultrasound to do that.
You mentioned that there was the international study of 10,000 people. When it comes to the work that you've been doing, I imagine you're working at a slightly smaller scale.
Yeah, so we tend to work on studies that are powered often to look at fairly specific differences in the flow of blood, but also in markers that link to how well we control the vessels that allow blood to flow through the brain. And in essence, there's a relationship between the way in which our blood pressure changes and the way in which the brain responds. And understanding how closely linked that is, and also understanding whether the brain is responding appropriately to insults, for example, like high blood pressure, low blood pressure, etc., is where we sort of focus our efforts. We tend to conduct studies that are somewhere between around 20 participants up to around 60 to 75. And we're fortunate now, having done a number of those sorts of studies, we've almost created a little bit of a biobank of recordings that we have amalgamated both internally, but also we've got colleagues in Brazil who have been conducting assessments in their populations. We're fortunate in the past that we've compared different ethnic groups to look at whether there are specific differences in the way we control blood flow or blood flow at rest. And increasingly now also we can compare different conditions. So just to name a few, between Lucy, myself and some others, we've got data on multiple different dementia subtypes, different stroke subtypes. We've got Parkinson's patients, a variety of different aged, healthy individuals. So it's really now sort of evolving such that almost all neurodegenerative conditions, we've collected some data on, often published those manuscripts and shared them more widely. And we are now collaborating as part of a multi-centre collaboration that Lucy and I are leading here in Leicester from an analysis perspective, which is pooling several hundred recordings together from around the world to try to answer some of the big hitting questions that remain in stroke.
So that's the Infomatas project, which, as Justin said, is a multi-centre collaboration. I think we've got data from quite a number of countries around the world now, and that's been organised through an international society called the Cerebral Autoregulation Network. And we're currently just reaching the analysis phase now. So we've been collecting data from all the centres and compiling it. It's been quite a big project for me to work on and a bit challenging at times, working with so many different groups in so many different countries. I've just had fun trying to arrange a meeting with all the various time zones for the end of this month. And we've been supported by some help from Keele University with that, who are experts in this particular type of analysis, which is known as individual patient data meta-analysis. And it's where you take data from all the individual patients in the studies, rather than looking at the overall analysed data from studies, which is how we normally put data together from lots of different studies. And this is just a much better way of doing it, because it means that we can put in lots of different characteristics about the patients, things like age, medical conditions they have, like diabetes and high blood pressure, and we can look at how those all interact with metrics or markers of brain blood flow to basically relate to stroke and what their outcomes are from stroke and things along those lines.
What are the steps it would take for someone to go from walking around living their life completely healthy as far as they know to being involved in the CogFlow study?
So we did take some people who were healthy and walking around, so they were able to come straight into the study as they are. We did ask that they were an older participant, so we took anybody above the age of, it was either 50 or 55. We didn't set it too high because we also wanted to capture people with a younger onset profile of dementia as well. The patients that we recruited to the study, we took a group that had sort of this intermediate stage, so mild cognitive impairment, which is where people are able to function in their everyday life. So they can go to work, they can drive, do all their usual things, cooking, finances, but they have noticed that there's something not quite right with their memory, and they've probably gone to see their own doctor, their GP about it, and they've often been referred on to the memory clinic where they do some assessments. And we also identify in the memory clinic that there is a memory problem there, but it's not so bad that it's causing them a day-to-day issue. And this group we're particularly interested in because they're at an early stage where they might go on to get dementia, they might not. And we don't really know why some people do and some people don't at the moment. But that group, we might be able to identify them and potentially try and put preventative strategies in place to stop them from going on to get dementia. And then the other group that we also recruited for the study were people who had already had a diagnosis of dementia. So they were the next stage on from mild cognitive impairment. And those participants have an obvious problem with their memory. So they may have noticed something, but sometimes it actually might be a carer or a family member, a friend or relative who's noticed that something's not right with their memory and has sort of helped them along their way to see the GP and get into the memory clinic, where we then do some tests, which would involve having a brain scan usually, which could be a CT or an MRI scan, blood tests usually done through their GP, some memory assessments with us, and we'd also talk to them and interview them and ask them lots of questions about their memory and what they've noticed, what their partner, relative or friend has noticed. And then based on all of that, we would give a diagnosis of dementia and try and identify the subtype, which is usually Alzheimer's disease or vascular dementia. And providing they had Alzheimer's disease, they were able to enroll in this study as well.
And in terms of ability for them to advocate for themselves or have carers involved in making these decisions, how has either this study contributed to building those communities, or how have those communities contributed to the study, and what kind of relationship is there between the both of you going forwards?
We did have patient and public involvement, which is becoming a much bigger part of research these days. And personally, it was a part of the developing the study that I really enjoyed. So through the Alzheimer's Society, I was supported to develop a patient public involvement group who were either people living with dementia or carers of people living with dementia that were able to give me input into the design of the study, and also review things like the information sheets, consent forms and the consent process to make sure it was sensitive and applicable to people living with dementia. They also tried out quite a few of the brain training games for me to make sure that they were at least doable for different stages of dementia as well. Although part of the study was also to investigate those sort of things. It was a lot of fun working with them to try and develop the study ideas a bit further. And we always make sure that we do that over coffee and pastries, which is always a nice part of the meeting. This was pre-COVID, where we could have face-to-face meetings with coffees and pastries. So that was a really nice part of the study. And then in terms of the consent process, one of the things I did was I put in place a procedure that if the person with dementia was unable to consent for themselves, the assessment would have been done by myself, because I have experience of working with people with dementia, both clinically and in research, that a nominated person, so their carer or friend or representative, as long as they knew the person well and could suggest on their behalf that they would want to take part in the study, they were able to complete something called a personal consultee declaration, where they are able to declare that that person would want to be involved in the study. And if there was any signs of distress, so if the person were clearly not enjoying the study or having the procedures done to them or weren't able to engage with the brain training, then we wouldn't have pursued the study in that sense. So we screened quite carefully to try and make sure that wasn't the case. So I didn't really have any instances where that occurred. But on the whole, as much as I can, I try to support people living with dementia to consent to the study. And that's by making a suitable environment, having plenty of time, making the information sort of logical and understandable and not using too much jargon. And that was partly the reason for having the patient and public involvement group, was to make sure that we were able to do that, so that the information sheets and the consent forms were suitable for people with dementia.
Now, there's more to be said for the methodology and analysis, but skipping ahead to the results, what kind of interventions are you finding are worth pursuing for these people?
In a very initial study I did looked at ultrasound to distinguish different types of dementia and sort of mild cognitive impairment and Alzheimer's disease. And we did find that using a language-based task, so asking people to repeat certain words and phrases and looking at their blood flow responses, we could see that blood flow responses were much lower in mild cognitive impairment, but even lower in Alzheimer's disease. That was quite an interesting finding. That was something we did before moving on to the cognition and flow study. In the cognition and flow study, we found that after people had done brain training for 12 weeks, in healthy older adults, brain blood flow responses tended to reduce, which sounds a bit counterintuitive, but actually in older adults, they tend to overactivate their blood flow response. So they try to increase their blood flow response almost too much to try and compensate for not being able to do the memory test or question. So actually reducing blood flow responses in those people might show that the brain's getting more efficient and acting more like a younger brain. Whereas in people with Alzheimer's disease and mild cognitive impairment, I found that blood flow responses tended to increase after the training. And because they have lower blood flow responses compared to healthy older adults, increasing the amount of blood flow when they're challenged might represent the brain working better for those people as well. It was quite a small study. We were really a study that's been done to see whether we can take this to the next stage and kind of do it with more people on a bigger scale in different centres. And I think that we have enough information from this study to be able to say that, yes, it would be interesting to take this forward and investigate that in a bigger sample.
Taking those lessons, is it something that you think would be changing your practice in terms of dealing with stroke patients in the pre-degenerative state?
I think it's a question of thinking about the concepts that Lucy and I are applying to understanding blood flow and manipulating blood flow. If we take a step back, then what we essentially think is that mechanisms that will allow us to either increase or decrease blood flow, preferentially in different circumstances, for example, where there might be low blood flow in dementia states, trying to increase that blood flow, or indeed, for example, where there's too much blood flow in a context where, for example, there's been some bleeding onto the brain. It's about trying to think about either maneuvers and strategies we could do to control blood flow, or indeed thinking about how we might then be able to take things forward from our understanding perspective to think about medications and the effects that they may be able to have on brain blood flow. And so, although some of these concepts are still in their infancy, there's so much to do in terms of trying to understand whether these are consistent findings that we've had within our various studies, and also whether there are options to extrapolate this to larger populations and think about larger trials, really. So I think it's exciting because we perhaps have understood a bit more about these conditions than we may have done, perhaps just focusing on some of the clinical aspects and ignoring what's actually going on in the disease process.
And speaking about all these potential future trials, is that something that you are putting the paperwork together for now, or are there still a few other loose ends to tie up?
Well, I think between us, we hope to continue our various work streams to develop larger studies. I think a big part of it also is working with different colleagues. So I've spent a bit of time in Canada, Lucy's just spent a bit of time in Nijmegen, and these different groups are leaders in the field, and what they will provide us with is a sounding board for some of our ideas, to reflect on some of the data that we have gathered, and also to perhaps pull data, as you've already mentioned, and then begin to bring some of these ideas to our annual international conference that happens through the Cerebral Autoregulation Network, and then begin to pick apart how we can, answer the next set of questions. And obviously further grants, different patient groups, different trial designs. These are all things that I think we're, correct me if I'm wrong, Lucy, constantly thinking about.
Yeah, Jatinder and I are always meeting to discuss what we can do with Chiasm and how to take it further, really. And I think we're looking forward to working on quite a few joint projects going forward. We've had the opportunity to publish a few papers together, which has always been a good experience, and I hope we continue to do so.
And for anyone listening to this who wants to get involved from either the peer and professional side or possibly from the patient participation side of things, are there any useful resources that they should aim for online, or any professional groups or peer support groups that might be able to coordinate for that?
In terms of sort of peer support groups, the Alzheimer's Society is really helpful for people living with dementia. Alzheimer's Research UK is a major research funder for dementia studies. Me and Jatinder have been talking about the Forward Stroke Group in Leicester, which is part of the Stroke Association, which is a really great patient group for people living with stroke. If anybody would like to follow what me and Jatinder are up to going forward, find us both on Twitter. So my Twitter handle is @lbshan.
And at Dr. J. Minhas.
I think we're hoping to get our web pages up to date, but you can find the Chiasm group on the University of Leicester web page as well.
I think it's also important that we express we're always interested to hear from people that want to get involved in brain blood flow. We're shortly to start an ultrasound course based in Leicester that's going to continue to train, hopefully, the next generation of ultrasound focused researchers. people are interested in master's degrees, PhD study. Lucy and I have supervisor experience and are keen to hear from people interested in exploring these opportunities with us in the Midlands.